Can everyone see that? Make it bigger.
So this fella, he's 22 years old.
Wait, is it 3080? Is he 31 years old, or is that correct?
Oh yeah. I looked at it wrong. He started using drugs at age 22. I'm sorry.
Oh no, you're
30
fine. Just making sure.
Yeah, he's 31 years old. He's slightly mentally impaired. He's not able to read or write. He kind of got mixed up with the wrong crowd, I think, when he was younger. And then got hepatitis C, he feels like as soon as he started using. He lives with his dad. He doesn't have a girlfriend, or he's not married, and he is in the Suboxone program here at Southern Collins. He doesn't have a whole lot going on as far as comorbidities, vitamin D deficiency, he's got some depression, and then of course the history of substance abuse. His medications Abilify and Suboxone. I would not think there would be any reactions with either of those for the medication that I want to prescribe for him. He's immune to both hepatitis A and B. His lab results are mostly in normal ranges. His ALT was a little bit elevated, and AST was a little bit elevated. His viral load, 105. I gotta think about what that is meant. Anyway, you can see what his viral load is there. And then he's a genotype 1A. His MELT score was only 7. His APRI 0.57. So I don't feel like he's going to need long-term follow-up with this. I feel like he will be a fairly
Robin,
Yes.
I hate to cut you off. You are a little bit hard to understand.
Okay, maybe do I need to get closer to? Maybe I need to turn the volume up.
It's like coming in and out. Is everybody else hearing that same thing in the chat? It might have popped up that way.
Robin,
Okay.
you can try turning off your video. That might help a little bit.
Okay.
Maybe just a little bit.
How's that? Can you hear me better?
A little. It's just, yeah. I don't know if it's the mic picking up your voice. It's just, somebody put it perfectly. I think garbled. You know what I mean? When it sounds like muffled a little bit.
All right. Well, maybe if I talk slower.
Sorry,
Okay.
I think it's okay. Sorry, everyone. I'll try and follow along and try to point with my little hand as much as I can.
Okay. I don't know if anybody heard any of the. So he's genotype 1A. I feel like he's going to be a fairly simple patient to treat. I think if we do Maverick on him for 8 weeks, I think he'll do well with that, and we won't need to do any kind of follow-up with him. His fiber score was low, and so I don't think that he's got any effects that are going to be long-term.
No worries. Thank you so much. Go ahead, John. I saw you unmute.
Yeah, hey, I could understand your garbledness. I think that was perfect. You did good.
Okay.
So I think Mitris talked about resources, and it just made me think if there's anybody new on the call, and now Quinn, you might not know what resources we go to, but hcvguidelines.org is still the go-to for treatment recommendations and stuff like that. Wonderful free resource. So hcvguidelines.org. Agree with you 100%. This patient is non-cirrhotic, treatment naive, no drug interactions. Great one to start with. So genotype 1A. Our treatment options, basically the easy treatment options would be anything except Zepatier, because you'd have to do that little polymorphism whatnot if you wanted to use that drug. So you're good to go with Maverick for 8 weeks, Epclusa for 12 weeks, or again, because he's a non-complicated patient, non-cirrhotic, non-HIV infected, and a viral load less than 6 million, you could technically give him Harvoni for 8 weeks too, if his insurance permitted something like that. I know we usually don't suggest Harvoni because it's not on the Medicaid preferred formulary, but I think this is a great candidate. Hopefully his mental impairment is not to the degree that would inhibit his adherence to medications. You think that,
No, he's so excited for his treatment that he can't stand it. So I feel like he's going to be 100% compliant.
Awesome. I can't make him any more complicated than that. I don't see any extra hepatic whatnot. Everything seems good to go with any of those treatment options. And then, like agreed, no need for early imaging or long-term follow-up.
Okay.
Perfect. Thank you so much. Any other questions or comments before we move on to the next case? Awesome. And thank you so much, Mitra. She included that website that Dr. Gilfus just had mentioned. All right, I will share the next case. And this is 3081 with a 35-year-old male.
This gentleman is 35 years old. He has a history of IV drug use. He was clean for a year, but then his mother passed and that caused him to relapse. He is in the Suboxone program here at Southern Highlands. His history of drug use started about 12 or 13 years of age. Am I still garbled? Can y'all understand me now?
You're doing great. No worries.
I might have just been talking too fast. Who knows? He was in jail for a couple of years, and so he had a couple of jailhouse tattoos as well. So he thinks that's where he got hepatitis C, but he's really unsure. His girlfriend is a recovering addict, and he has 2 kids. As far as his medications, I don't see anything that's going to cause any kind of interaction on his medications. He is on vitamin D supplementation because his vitamin D was only 22. His liver enzymes were slightly elevated, but obviously much worse. All of his other lab work looked okay. He is only a MELD score of 6. He did have a positive Hep B core, but luckily for him, he is now immune. And his fibrosis marker was only 0.24. So no fibrosis there. With genotype 3, I feel like probably Maverick is going to be what I like to use on him. And I don't know. I think with genotype 3, I probably should follow up with him maybe in 6 months. I just need a verification of that for, just, I don't know. I feel like that one was the one that can cause worse problems. So I thought that I needed to get a little bit more in-depth study of his liver. At some point, we did an ultrasound back in January on him. It just showed a non-uniform hepatic echo texture. Not anything really that was a problem with his liver at that point. So the only question with him is, do I need to follow up, and can we do Maverick?
Great. Thank you so much. Go ahead and unmute if you have any questions or answers to those.
Hey, Robin, it's Kaylee. Thank you so much for presenting this case. I had a couple just clarifying questions just to ask real quick. The main one was in regards to the Hep B, just because I know you said his core was, let me just make sure I'm correct. Core was positive, core antibody positive, and then surface antibody was also positive.
Surface antibody reactive. So
okay, I just wanted to make sure, because when I was looking at the case, I saw who is it had listed Hep B as a comorbidity. Okay, okay. Just
his, I think initially he might have had a Hep B, like a recent exposure, but then when we rechecked, his Hep B was reactive. His antibodies were reactive. So
were reactive and surface antigen negative.
Right.
Okay.
Wait,
okay. Just
look at his surface antigen. No, I know the antibodies, but the antigen, the AG. Let's see what that one shows. She's looking on the other computer because mine's tied up here.
sure.
The AG. The IgM was negative. Is there an AG? Yeah, I think it was negative.
Okay. Okay. Which would make sense if his surface antibody is positive, but just for everyone else on the call, just remember when we're checking hepatitis B serology that we're doing hepatitis B surface antigen to assess for active infection, and then hepatitis B surface antibody will assess for immunity to Hep B, whether that be through natural infection or vaccination. And then our hepatitis B core, and this should be the core total antibody, assesses for exposure to hepatitis B virus. So in this instance, it seems like he's been exposed to Hep B in the past. In most instances, as adults, this is about 90%. If they've developed Hep B or come in contact with Hep B as an adult, they will control the virus and so not be at risk for reactivation. That's what his case looks like. He has prior exposure, but good immune response. The people we worry about treating with Hep C direct acting antivirals are those that have either surface antigen positivity or isolated core positivity. And in those instances, we can actually preempt Hep B reactivation when we start Hep C treatment. So just kind of brief overview, just for everyone on the call, if we haven't reviewed that recently. This gentleman, I'm not worried about that in him. The other couple questions I just wanted to ask was, with his recent relapse, do you know if he shared any works, or was it through injection use?
Injection use.
Okay. I just try to be upfront with patients too, because I mean, I know relapse happens, and he'd been sober for a year and had a situation come up that, you know, triggered that. But just try to make sure with all the patients, just being open about if relapse happens, just making sure to not share any of their injecting equipment, and just counsel on harms of substance use and relapse, and trying to make sure that they're using sterile works every time and not sharing, just so that they're avoiding reinfection, because they can always get reinfected with Hep C even after treatment. Do you know his girlfriend's status? Has she been tested for Hep C?
I think she has been tested, but she sees another provider. She doesn't come in.
Okay. Okay.
I really can't remember. I don't have that. No, go ahead.
If she's positive, it's probably worthwhile that their children are also tested.
Okay.
But you know, and then she can also get linked into care also. But if she's negative, then, you know, their children wouldn't necessarily need to be screened unless they'd had blood exposure to this patient. As far as your main question, so you could do Mavorite times 8 weeks, or Epclusa for 12 weeks. You know, a lot of people do prefer that shorter treatment duration, so Mavorite times 8 would be reasonable. Remember, if you have genotype 3 and cirrhosis, so it doesn't seem that this gentleman does, but if you have genotype 3 and cirrhosis, that warrants that baseline polymorphism testing, that resistance testing, before using Epclusa. So just kind of keep that in mind too. And then the only other comment I would make was about you'd questioned if he would need kind of long-term follow-up because of his genotype. As long as his liver enzymes normalize during and after treatment, and as long as he doesn't have any underlying advanced liver fibrosis, he won't need any long-term liver monitoring post SVR12. So he would just still need that SVR12 data. Okay.
A question about, it's not specifically about him, but back to the hepatitis B.
Sure.
I've had several patients with their core is positive, and then the antibodies are positive and the antigen is positive. I've got several like that. At that point, do I assume they probably had a recent exposure and then they're developing antibodies, so I don't have to worry about it, or is that something I need to take a viral load on?
Now, are you vaccinating these patients at the same time when you see them?
If they need it, they're not reactive and their core is negative, then I am, yes.
Okay, because sometimes so a surface antigen, it seems like that would be more of a false positive. I wouldn't expect to see a positive surface antigen, surface antibody, and a core antibody. And so, I mean, it could be possibly a false positive surface antigen. You could always repeat. Sometimes too, if you vaccinate a patient at their visit, like sometimes if I see a patient, I'll just bring them in. I'll say, hey, let's go ahead and do Hep A and B vaccines. That way, at least you have it, and then send them down for labs. But sometimes if you vaccinated same day or within a few weeks of their lab draw, then that surface antigen can be falsely positive as well. I would just repeat that serology on those patients too. I wouldn't expect that if they've had a recent exposure that they would have both surface antigen positivity and surface antibody positivity at the same time. John, do you have any other input with that?
No, I think that was beautifully said. That's not supposed to happen, but Lord knows I've seen every combination that's not supposed to happen with hepatitis B. But Kaylee said everything perfectly. Agree 100%. Yeah, and that just your question about the long-term follow-up, that APRI is a little high, but I agree with Kaylee. All I would do is make sure that that normalizes. I'm sure it will. The transaminases will normalize really quickly on treatment. Then you can recalculate the APRI and it'll be like nothing. It's just, remember, 0.7 is that threshold where it makes you say, hey, is there something going on? But it doesn't really predict cirrhosis or anything like that. And obviously the biomarkers are comforting. So yeah, I think it's a great case to treat before something bad happens. And yeah, we've had a bunch of false positive surface antigens. So that's why Kaylee and I are suspicious of that.
Okay, I'll keep that in mind. Now, if I have something like that pop up again, I can, even though this echo is not about Hep B, always it's Hep C, but could I email you about that?
Heck yeah, or present it. Yeah, we love Hep B. We'll you can
Okay.
talk about it anytime.
Yeah,
Okay,
Robin, present it because it's beneficial for everyone on the call. So yeah, we'd appreciate those cases so we can work through those together.
Okay, great.
Awesome. That is great. Thank you guys so much for that feedback and great questions, Robin. Yeah, present it for sure. I mean, this helps others that can't make it as well when they watch it. So we really appreciate it. Do you have any other?
The other clue would be on your core antibody. If it was just IgM positivity, it would, help you. If it's just IgM core and not IgG core. But yeah, man, I could waste our whole visit on that one. Sorry about that. We'll talk about that another time. But good case.
Maybe we can have a case on just hepatitis, or not a case, but a presentation just on that soon. That'd be great.
Absolutely, we absolutely will.
That sounds great. Thank you so much. Put that on the topics list. All right, we'll go to that next case. Give me one moment, please. All right, this is 3083, and this is a 41-year-old. Is that correct? Are you good, Robin, with that?
Yes, yes, correct. Okay, so this gentleman started using marijuana and alcohol at age 11. And at age 24, he started using IV drugs. He has been in rehab several times, but he feels like this might be the time that he stays clean. He lives with his dad. He has a wife and 2 children. And I am not sure. I usually always ask them, but I really can't remember if his wife was positive or negative. But I'll find that out and see if we need to test her as well. He was actively using drugs for about 30 years. He doesn't drink alcohol at this time, and he currently has a job. So I think he's on a good track to be a good candidate for treatment. His comorbidities include vitamin D deficiency, which we are supplementing, anxiety and depression, hypertension, GERD, and asthma. His medications, I don't think that there's any of his medications that should create a problem with treatment. He is immune to both hepatitis A and B. Liver enzymes were pretty significantly elevated. His MELD score was 6, APRI 1.4, and his child Turco-Q was class A. He's genotype A, and I feel like with his relatively low viral load compared to others, that an 8-week Maverick treatment would be good for him, and I don't feel like he'll need follow-up after that. Let me look at his fiber. And I feel like he'll probably be okay without follow-up after his SBR 12, which is good. That's all.
Thank you so much. Any clarifying questions about this case?
Hey, Robin, this is Kaylee again. How long has he had this diagnosis? Do you know?
I don't. I'll have to look in his chart.
Okay. How do you know how long he's been sober?
106 days.
Okay, so it's been a little while now. Okay, over 3 months. I just, do you happen to have a trend of his AST and ALT, or is the value from July the only recent one on file?
I mean, I'll have to look. Do we have another? We can look at his CNP for me. I'm taking computer. Okay, look at his CNP. Mandy just found two. Mandy is I told you she's the one that does all my footwork on this, but she said his has been treated too. So
his wife was treated too. Okay.
well, they're currently separated, but they're still on friendly.
Sure.
terms.
Sure. Okay.
Not sexually active according. We're a CMP, like liver enzymes prior to the one in July. They've been hiring out. What was the last one?
The last one was 149, 367.
149, 367, and then they went up for the one in July.
Okay.
So they've been fluctuating up and down.
Okay, but they've been persistently elevated for some
Yes.
time. Okay. Yeah, I mean, you could certainly do Mavorite for 8 weeks with this patient, and remember the other alternative would be the Epiclusa for 12, but he's on that pantoprazole, the reflex medication, so there's some drug interactions with that. I would continue to follow his liver enzymes, making sure that those normalize during and after treatment. I probably check him again in about a month, just to make sure they're trending down. If they stay persistently elevated, I'd be a little bit concerned there's something else going on and he needs to be investigated for alternative causes of liver disease as well. And he is somebody I would go ahead and grab an ultrasound on.
Okay.
Just to assess his liver contour. I know that his FibroSure was reassuring, but just that APRI is high. He's got this persistent transaminitis, and that's a little bit worrisome to me with that degree of liver inflammation. I'd say go ahead and snag an imaging on him.
Okay. When you said check the liver enzymes in a month, you mean 1 month after he finishes treatment?
Yep. 1 month into treatment is what I typically would check. I just like to trend them a little bit closer when they're that high.
Okay. All right. I'll do that. Okay.
Yeah, Mitra or Elizabeth, could you guys share my screen for a second? Can I pull up something?
Yes, of course. There you go. I made you a co-host. Dr. Gilfus, is it working for you?
Yeah.
There we go.
Can you guys see that?
Yeah.
Kaylee's astutely pointing out this fact. And I had this cool slide. I was like, holy crap, this is so pertinent. So what Kaylee was saying is, those liver enzymes are so high that it almost seems like they're in that acute zone. And there's some definite wisdom of trying to see whether or not they're in that acute zone. So if you're somebody with really high liver enzymes from the start, you're more likely to clear it on your own. That's what the top curve shows. It says, hey, look at this. In 6 months, I cleared it on my own when I had this really kind of vigorous immune response up front. Remember, those that clear Hep C on their own, it's not a virologic property, it's a host property. It's something unique about the host immune response, and those people also tend to get really high liver enzymes. Because I was a tad freaked out too, like Kaylee, at the APRI and just the degree of liver enzymes. I'd definitely make sure that normalizes it. And yeah, if you could always get a third data point to triangulate, like elastography, would be great.
Thank you so much, Dr. Gilfus. He always has those like amazing tidbits in his like back pocket. I love it.
I just have like 600 PowerPoints and everyone's pertinent.
That's awesome. Thank you. Robin, do you have any further questions on this case before your next?
I don't think so.
Perfect. All right. Thank you so much. And thank you, Kaylee. All right. I will pull up the next one. Just give me a moment.
I think so.
All right. Perfect. 3084. And this is a 34-year-old male.
Okay. This man has been clean since February of this year. He is currently working full-time, doing construction. I really wish that, this guy's got some interesting neurological stuff going on, and I've yet to come up with a diagnosis of that, but I'll mention it just because it's interesting. When he's got a head jerk that he does it here. His head jerks to the right just when he's speaking. And whenever you test reflexes anywhere, legs, arms, anywhere, his head jerks to the right. So I don't know why. That's something odd. I've never seen that, and I'm not sure why it does that. And we sent to neurology, but that's yet to happen for one reason or another. He just can't seem to get there. But anyway, so he has spastic tremors. That is one of his comorbidities, and we haven't yet found the diagnosis for that. And of course, history of IV drug use. He is immune to hepatitis A, and he's currently receiving hepatitis B vaccinations. Lab work, relatively unremarkable, other than slightly elevated liver enzymes. APRI score 0.945, child Turco-Pugh class A, and a MELD score of 7. Vitamin D was in normal range. We don't have him on that right now. I might probably should go ahead and put him on some vitamin D anyway, because I think that you guys told me it'd be better if it was above 60. And so his is only 48, so we might add a supplementation to that. And then he's genotype 1A as well, low viral load. Serum fibrosis biomarker is 0.45. Again, my favorite Maverick is what I'm trying to treat him with. And I just need to see if that's acceptable and if there's anything else I need to do with him.
Great job. Thank you so much, Robin. All right, the questions and answers portion.
I was giving John a chance, but I guess not. This is Kaylee again. Thanks, Robin. I agree with everything that you're saying. Maverick ×8 would work. The only I guess caveat I would maybe consider, just ask him, just because he is traveling for work and does construction, just if a food dependent regimen would be reasonable for him. It may be hard for him to eat, during the day or when he's taking his medication. So if can't take it with food, then the Epclusa for 12 weeks would probably be the better option for him. And then just with that one also, being a Medicaid patient, if you do go with Epclusa, actually it's the generic sofosbuvir velpatasvir that is on formulary, not the brand. But if food isn't an issue, Maverick for 8 weeks would be excellent for him. And then the neck tremors, does he have, is that new? Or
No,
something
he's had it for a while, and he said he really didn't realize it at first until some of his friends started commenting, and then he's more aware. And then when he tries to stop it, they get a little bit more severe. When he's awake.
Sure.
It's just a really odd. I've never seen anything like that. When you do any reflex, the head jerks to the right. So if anybody has any ideas, I'll be more than happy to hear those about that too.
Yeah, I mean, the only thing I can think of is like torticollis or like cervical dystonia, but I'd say safest bet is go ahead and refer to to neurology, just to make sure it's not something more serious.
Okay. All right.
Great. Thank you so much. Any further comments?
I I don't even know how to do a neurologic exam anymore. So that sounds like definitely neurology. But I put into Google, or actually never mind. I looked in my binder and under movement disorders and autoimmune disease, and obviously there are some autoimmune diseases that can cause movement disorders. And if you say the word autoimmune disease, remember hepatitis C might have some relation. So that'd be awesome. What if you treat this guy and whatever reaction gets better? That'd be let us know on that one.
Yeah, that would be awesome if that happened, because
I probably wouldn't promise him that though.
no, I won't even mention it on this. I'll just watch. I mean, do you see hepatitis C cause a lot of neurological or any neurological?
Yeah, I mean, it's neuropathy is the classic, a non-symmetric neuropathy. So it via sort of antibody immune deposition into neurons, you can have a mononeuritis multiplex. So you certainly can have that. You can also have a vasculitis, CNS vasculitis, but it shouldn't do what you're describing as far as I know. Again, that's so far from my specialty. It's embarrassing. I remember there's a brain, and then, well, that's about it.
I love it. All right, any other questions or comments? All right, perfect. We'll go on to the last case. Yeah, Julie, did you unmute for this moment? Or are you good? You're good? Okay.
I'm good.
All right, perfect.
Thank you.
Of course. All right, this is case 3100 and male 28.
Okay, 28-year-old male who started opioids at age 24 due to an injury. So he started using IV drugs then at age 27. Opioids, heroin, and fentanyl were his drugs of choice. Does not drink alcohol. He's currently unemployed. He's kind of up in the air about what he's going to do with his life after this. But he feels like he does have a good support system at home. He has been treated before. Do you know what he was treated with? He did not know the name. He says it was about 4 or 5 years ago. So if I need to know that, I can probably call where he had it before and see. Vitamin D deficiency, anxiety, substance abuse, constipation, depression, insomnia. That's his comorbidities. His medications, I don't see any that could cause a potential problem. I do remember at some point somebody said something about Maalox. I think that's only like a PRN medicine for him, so I don't think I need to worry about that one too much. He is immune to both hepatitis A and B. WVC's a little bit elevated. His liver enzymes, his ALT slightly elevated, not significant at all. Child Turco-Pugh class A, APRI score of 0.349 and a MELD score of only 6. With his HIV negative genotype is 1A, and serum fibrosis marker is 0.34. Again, Maverick. I'm not sure why anybody would lose anything but Maverick, but anyway, that's what I'm thinking. Maverick for 8 weeks.
Great, thank you so much, Robin. Any clarifying questions to that case? All right, so go ahead and do any of the recommendations for the Maverick.
I guess it's Kaylee again. Robin, surprise, surprise. No, John, I think John just got on a Mars call, so something with service. I'm not I shouldn't say as concerned that he's been exposed to treatment in the past, other than, do you know if he achieved SBR at that time?
don't know. I'll have to investigate that. He had it locally at one of the GI docs offices.
Okay.
So I can call and get that.
Yeah, he would be somebody I may hesitate to treat again too quickly, only because he's already used these resources before. I would clarify if he did actually complete treatment the first time, the full course, and what it was, and if he achieved SVR 12. Just really to differentiate, is this a reinfection versus a treatment failure?
Okay.
Since that's been a while ago, because that would actually change your management a little bit. If he was a true treatment failure, so didn't achieve SVR 12, he would actually need to be treated with Vosevi times 12 weeks. And then if this was if this is a reinfection, the Mavra, and I would also maybe try to see if you can find out what genotype he was before. I mean, chances are, since genotype 1A is so common, it wouldn't be unlikely that he would get reinfected and have the same genotype anyway. But if he was treated with a different genotype previously, that may also further kind of sort out if this is reinfection or not.
Okay.
If this is a reinfection, Maverick for 8 weeks would be a reasonable option, but I probably would follow him for a little while before jumping right back into offering treatment again, particularly because he's still using recreationally and has already been treated once. I would just be a little bit hesitant, because I think that you might have to jump through some hoops anyway to get him retreated.
He's not
with
currently
insurance.
using, but
Oh, okay.
yeah, he's in a long-term program right now. So
Gotcha. But yeah, typically kind of my threshold, and this really is based on, your feel for the patient. But if I've had somebody that's gotten reinfected, I usually follow them for.
You went on mute for a moment there, Kaylee. Last thing I heard you say
Oh,
was
so
yoga.
sorry. Oh, so sorry.
Okay.
I must have just hit a button accidentally. No, what I was saying was that in my patients that have come back in with reinfection or are needing retreatment, I'm usually just a little more conservative with offering that, just because we have such limited resources in our state. So I typically follow them for about a year, just to make sure they're staying engaged in care and that they're not at risk for ongoing infection. I do follow them for a little bit while longer before offering retreatment, because there may be some hoops to jump through, especially with insurance.
okay.
Great. Thank you so much, Kaylee. Anybody else have any questions or comments? Or Robin, do you have any further questions as well?
I don't think so.
Excellent.
I just got off the phone, but yeah, it's beautiful advice. 100% concur. Definitely can change your treatment approach. So collecting that data is probably important.
Thank you very much.
I'll call and find out.
Yes, and thank you, Kaylee. And just so you guys know, the spokes you guys can speak to. Please feel free. If you feel confident in an answer, you are welcome to give advice. We want to hear from all of you. Don't be shy. All right. Does anybody have anything else before we end today?
Hi, I have a quick question. I'm literally about to step in the room with my first patient with Hep C, and he's 34, former amphetamine user, and had positive viral count like 2 or 3 years ago. That was like a log 6 and genotype 1A. So I have a sense of all the typical labs. I was gonna order him today, but then also was wondering whether either the elastography or the FibroSure were things that are needed while we have them here today in the planning stage.
Quentin, do you have elastography readily available where you're at?
Most likely not.
Okay, I would say a lot of places don't. That's why I asked that. I would snag a FibroSure on him or Fibro test, whichever you guys have, just because if you're submitting him for treatment, that's one of the requirements, is to either have Fibro test or elastography. And so, and if his liver enzymes are elevated, then I would also go ahead and snag a right upper quadrant as well. The elastography we prefer, but a lot of times we can't get access to it. So if you at least have an imaging modality and then the fibro test, that should suffice. And then I would still, just since it's been a little while, still go ahead and repeat his genotype and viral load, of course, as well, and HIV testing and Hep A and B serology, that kind of stuff, liver enzymes, those things.
Most of our labs go through WVU at St. Joe's. In order within WVU, do you get the genotype automatically with the counts, or is that a separate? Is that like a separate order?
It's a separate order. If you just type in hepatitis C genotype, it's the only one that'll pop up.
Okay, awesome.
Thanks.
You.
Good luck.
Awesome.
Submit that case, man. Yeah, that'll be, filling out the echo submission form is exactly what you got to do for clinical, like the labs. So that's
all the things you need.
perfect
Okay.
practice. Yeah.
Sweet.
Mitra and Elizabeth can get you that form.
Yeah, please send it my way.
Perfect. We will, definitely. And if you have any questions, please let us know. You don't have to fill it all out, just like the essential stuff.
Yeah, Quentin, you better present him next time.
Yeah, I sure will.
No pressure. It's fine. But seriously.
This is every 2 weeks, is that right? Is it once a month or every 2
Put
weeks?
the poor guy on the spot his first day. Come on.
Right? Welcome.
I'm here for I'm here to do things, not just watch.
Love it. Awesome. Very exciting. We're happy to have you. All right, everyone. Thank you so much. And thank you for those questions. I only have one announcement. Our next session will be October 13th with Carolyn Kidd discussing LGBTQ and adolescent populations. So thank you very much. And you have a wonderful rest of your week. See you in October.
Thanks, everyone.